I'd like to thank each of you for joining us today for our first ever BAMSI Grand Rounds and for Diversity, Equity, and Inclusion. I'd first like to start by thanking the Department of Medicine for co-sponsoring this event along with Hospital Education. Thank you to all the command, department, and service leaders who are in attendance today, as well as our Air Force colleagues from the 959 and the 59th Medical Wing. Today is a special day for our committee, and we couldn't be more proud to have Colonel Retired Dr. Jeff Hutchinson serve as our inaugural speaker. Dr. Hutchinson served 25 years as an Army pediatric and adolescent medicine physician. A known DEI expert and champion, he is uniquely qualified to help foster our DEI efforts here at BAMSI. He previously served as the Associate Dean of Clinical Affairs and the Chief Diversity Officer at Uniformed Services University. He is the CEO and founder of the Wade Alliance and currently serves part-time as an adolescent physician at People's Community Clinic, an Austin-based federally qualified health center dedicated to the underserved. He remains connected to the military through Uniformed Services University as an adjunct professor, associate professor of pediatrics. Without further ado, I introduce Dr. Jeff Hutchinson.
Thank you, Dr. Bowen. If you're okay with it, I'm going to stand up here because with even that little bit of an obstacle between us, this is not a conversation that I want to have with any kind of barrier. I have nothing to disclose, but this is not an easy topic. So in full disclosure, you are going to be uncomfortable. There are going to be things we talk about that you may not feel you want to talk about, but I want you to think about the time when you were a resident or a medical student and an attending asked you a question that you may not have known. That was uncomfortable. Or think about the time when you had to give a patient bad news. They have cancer. Their loved one has died. Think about that discomfort. That discomfort helps us to grow. That discomfort is what we're going to sit in today as we go forward. Now, I always tell people that I'm okay with interruptions. I'm happy if you have a question, if I say something in the meantime that you don't understand and you want me to go into deeper, we can talk about that. But I know the way these work. You're going to be quiet until the end, so that's okay. My goal is to do 45 minutes of a presentation with 15 minutes of discussion. We'll shorten it, lengthen it, depending on how you all do. But I am going to stop and make sure there's plenty of time for us to talk about what you want to talk about and what I've described. Okay? So the three objectives. The first objective is pretty straightforward. Data can be used as a tool or as a crutch. And we're going to talk about, as leaders, what do you do with that data? The second topic, I want to talk about inclusion. If we are going to be inclusive leaders, there are things that we can do to make our unit more inclusive. We're going to go through those. And then finally, getting down to the nuts and bolts. How do you actually make DEI policy part of your strategic plan, of your whole policy? We're going to talk about that too. DEIA, you're going to hear that a lot. Diversity, equity, inclusion, and assessment. I believe with any journey, we have to have a common starting place, right? We all have different backgrounds, different experiences. If we come to a destination from different places, that's okay. But I'd much rather start the journey together. So let's talk about some of the definitions. When I think about diversity, I think about a Gerber tool, or I think about Abraham Maslow's quote that I suppose if the only tool that you have is a hammer, you want to treat everything like a nail. So diversity can be visible, can be invisible, but diversity is the ability to accomplish more than one task. It's the tools, it's having more than just a box full of hammers to do what you want to do. That's my definition of diversity. For equity, equality is easy, right? Everyone gets the same thing. Equity, if you have more than one child, if you have more than one niece or nephew, you understand equity. It's that you don't give everybody the exact same thing. You give people what they need. I have a 6'5", 21-year-old who I will be happy when he finds a real full-time job. I have a 17-year-old who is a fantastic art, already thinking about his business in the future. I don't give them the same things. Equity is giving people what they need to have similar outcomes. Let's talk about inequity. Here in San Antonio, when you look at the difference between who is dying of COVID and who has the vaccination, you see what inequity actually looks like. On the map, in the top left corner, areas that are gray are areas where the numbers of people who've died from COVID are so low that they can't give anonymity. So the areas with the most deaths, central and southern. Compared to the map on the right, the light color are the areas with the most people fully vaccinated. And what do you notice? One of the counties with the most vaccines has the least number of deaths. If we really talked about equity, it would be just the opposite. The counties with the most deaths would have the most immunizations. That's how I look at equity. Inclusion. Renee Meyer's quote you may have heard before. Inclusion is, or diversity is being asked to the party. Inclusion is being asked to dance. I love it. It gives a very visual image. Those of us who had to ask people to dance, we understand that. So this is what I want you to think about, and think about the times when you did not feel like you were really part of the party. And then lastly, for accessibility, this is a classic example. The curb cuts. How a law has made it better for more than just people in wheelchairs, but people on bikes, mothers with strollers, people who have trouble just even stepping up on a curb are now helped by this accessibility option. And I want you to always remember that when we make things better for some people, we're likely helping other people too. So those are my definitions of diversity, equity, inclusion, and accessibility. I had my son, when I told you he was an artist, draw this graphic for me. Because to me, this brings all four of those concepts together into one image that makes a lot of sense to me. You see the equality versus equity, right? Same group of people, but they have different abilities. The diversity is you have different people, different abilities to use apparatus, different levels of fitness. And I especially like this in a military environment because we have a fat bias in military medicine, right? It's true. We talk about people, we treat people who are overweight a certain way. And we justify it because we have a mission. But there's definitely a bias there. So I use this. The diversity is different people. The equity is the fact that each person's apparatus supplies an equal amount of power to the projector. The inclusion is the TV. Everyone gets to watch the same thing. And the accessibility is having apparatus that can be used by different people. Where do we fit in as leaders? The leader's role in this graphic is to decide what's on the TV and to decide which apparatus should be included. So if I decided as a leader that there's just going to be stationary bikes, I exclude people. But if I start to include other things that allow people to give their power to what we're doing, I am more inclusive. And I will also tell you, the most challenging part is not the red person who didn't have an ability to do anything, but now with an apparatus can do something. Those people are motivated. The hardest challenge as a leader is the green person. Someone who is already producing, already contributing, and now you're asking them to do even more. That's going to be the challenge in leadership. Every organization loves the term data-driven. We want to be data-driven. We want to be able to say, we're doing this because the data says this is what we should do. I'm going to challenge you now to, let's look at that data a little bit. In diversity, equity, and inclusion, there are two main ways that we use data. One is by demographics. We break down how many male, female, officer, enlisted. We look at those demographics. The second one is with climate surveys. We ask, how do you feel about this? What do you think can be done better? Those are the two main ways that we use data. But the distribution matters. This is an example, say an organization with 500 people. Just if natural distribution was correct, if you took 5%, any demographic you like, 5% of black doctors, 5% of Latino doctors, 5% of people who are the LGBTQ community, this is what a random distribution will look like. Second law of thermodynamics says entropy should look like that. But what's the reality in most organizations? they are segregated. Most groups, most demographics are segregated to some sense. And this is not just theoretical. When you look at organizational charts, you see a segregation. Now, this should be a point where you all feel a little uncomfortable. You should start asking yourself, is this my organization? Where do I fit in on this? Well, my department chief is a woman, so this doesn't really apply to us. Think about all those. Think about the large organization, Air Force, Army, U.S. Senate. Think about how those organizations are and if this really applies. So distribution makes a difference when we take a sample. Let me go back. If I were to look at this and take a sample from different areas, there's a really good chance I might miss part of that demographic. Or if I sample from that area, I'm going to represent that one particular demographic. So distribution makes a big difference. Usually we say, put your phones away, silence your phones, but now I want you to pull your phones out. Some of you have used Poll Everywhere before, some of you have not. Poll Everywhere, you can either go to the website, pollev.com/USUHutch, or you can text USUHutch to 37607, and you're going to be put to the site. And I want to ask this question. I want to get a feel of where we are today. So, black male medical student applications have not significantly changed in the last 40 years. It's a fact. Here's some of the raw data. In 1978, there were about 1,400 applicants. In 2019, about 1,500 applicants. How about those who matriculated? 78, 542. And in 2019, 619. So the question I want to do, this is going to be a word cloud, so it's anonymous. I won't know who said what. But type in there, why do you think that is? What's the reason that there have not been much of a change in the last 40 years? Great. I'm glad that it worked because I wasn't sure if the internet was connected. So I know it's connected. Mentorship, bias, lack. And the lack, I assume, lack of candidates. We hear that a lot. Structural, demographic. Very nice. I had no idea what you were going to put. My guess was that it would be a pretty good cloud. My hope is that that would represent the diversity of people who came here. Because if everyone believed it was the exact same reason, we would see one big word pop out over and over again. But you have lots of great things. Education, models, exposure, barriers. All of these are great reasons. So keep those in mind. And if you want to keep adding things, you can. That's okay. But as scientists, as doctors, as those who care about finding out real scientific information, we know there's a difference between causation and correlation, right? So not having enough applicants leading to not enough black men in medicine, maybe that's true, maybe it's not. But we have to always ask ourselves, are we looking at the root cause? Are we looking at what is the reason that there is a difference in the number of black men in medicine? Let's change it around a little bit. So the first data point I want you to always think about is distribution. When we sample, we may not get the right sampling because if the distribution is segregated, we're going to miss some. This has to do with the next one that we're all familiar with, and it's confirmation bias. When we walk into a patient's room and they're coughing and wheezing and we know that it's asthma season, we're thinking asthma. So with this fact, in 1978, 22,000 white males applied to medical school, but in 2019, 11,000 applied. So there's a decrease. Someone may take that and say, well, that proves white males are being disadvantaged when it comes to getting into medical school. You might take that. You might also see those two facts. There's declining applications. That's a fact. That's true. You might also look at it and say that there are fewer being accepted. Again, that is a fact. That's true. Demographics have also changed. All three of those things are absolutely true. But there's more data. If you look again, 1978 versus 2019, look at the percent matriculants, males versus females, 1978 versus 2019. In 78, about 46% of males who applied were accepted. 2019, about 42%, so it went down. For women, it went up, 43 to 45. Asian males, it went up. And black males stayed essentially the same. I show you this not to argue one way or the other about that theory, but to have you have the same scrutiny that you have when you review a paper, when you submit a paper, when you look at data. Ask yourself, does this data really correlate? Does it really cause what I'm looking at? If you're not asking yourself that question with data related to diversity, equity, inclusion, accessibility, we're falling trapped to that bias. There are a lot of more biases, and we could spend an entire talk just about looking at data and looking at bias. But I want to sum up this one part with some of the common biases that we think about. Confirmation bias, you understand. If you've admitted a patient and then found out later you were completely wrong, you understand confirmation bias. Status quo bias. This one is near and dear to my heart because I spend a lot of time trying to get people to understand that the racial adjustment for GFR falls into the status quo bias. It is a way to show that data can be taken, historical data, and manipulated to come to an incorrect conclusion. Conclusion, how can you adjust for race my kidney function? It's because it's been done in the past. Underrepresented bias. If we don't get people from a certain group, we're not going to hear their opinions. Recall bias. You're going to remember the things that are most prevalent in your mind. If we're to do a climate survey right after the murder of George Floyd versus a climate survey right after the attack on the Capitol, you'd have very different surveys. So we tend to recall the things that we are exposed to. Selection bias, you understand, and primacy bias. The reason I'm starting with data is because I hope you remember that one the most. I really want you to think about data and what it means every time you think about diversity, equity, and inclusion. So, quick summary of this part. Know that there are biases and flaws in data, that if you build a team with different experiences, with different perspectives, you're more likely to evaluate that data in a clear and concise way. You're less likely to have all of the biases that we bring to the table because you have different people with different experiences. And then if you look at data over time, it's a much better indicator than just taking one particular point in time. All right. So Dr. Bowen didn't say, and some of you do know, I went to West Point. 1986, I was a sophomore. I was a cheerleader. We call ourselves rabble-rousers. Part of our job is before the games, the Friday nights, there's a rally. We get everybody hyped up down to the courtyard. So one Friday before Rutgers game, my role is to run through the barracks, yell for people, hey, come on down, we're having a rally. I know, it's what we did. While I was doing that, one cadet, likely upperclassman, but at that time nobody's in uniform, so you can't tell, he yelled at me a homophobic slur. I stopped, collected my thoughts, collected myself, kept moving, went down to the rally and did the rally. I tell you that because now I want to talk about inclusion. One single phrase can make you feel excluded. One single phrase and word can make you feel like you don't belong here, that what you're doing is othered. So the 54-year-old me now can look back and think, well, I should have done this, I could have done that. The 18-year-old me, I took that one incident and decided rabble-rousing wasn't for me. I just did it that 1 year. And I hate to admit sometimes that was one of the reasons why I stopped doing it. But if I'm going to be completely honest and transparent, which is what I ask all of you to do when we talk about this stuff, I have to say that one event is what made me feel like that wasn't right for me. So, when we talk about inclusion, people use the analogies of sports team. Anyone who's played a sport understands if you're on the same team, you have the same goals. Anyone who's been in theater or performances knows that even the person doing the lights and sound is just as important as the person on stage performing. But we who wear the uniform or who have worn the uniform have one more thing that we understand about inclusion. And that is what being on the same team, the military, really means. But you also understand that just because we wear the same uniform, it doesn't mean we always feel included. I spent over 10 years at Walter Reed, and the phrase "one team, one fight" was used, not just by Walter Reed, other organizations use it. It's very aspirational. It gets us to think if we're all working for the same goal, we can do anything. That's what I want inclusion to be thought of. Well, let's take meetings first. Let's take what can we do as leaders in 3 different situations: the actual meetings, the policy making, and then the selection process to make inclusion a little bit better. Your typical meeting, you've all been in a meeting like this. You've been in a room where there's the main table and there are chairs on the sides, and sometimes it's so crowded, you're one of the people standing. So first, physically, how can you make things better? Well, if I am a department chair and I show up and someone's in my seat and I say, you're in my seat, that's not very inclusive. What if it's a first come, first serve, except whoever the chairperson is, right? Everyone else who shows up sits anywhere at the table and is invited to the table before those chairs in the back are filled up. What would it look like if a department chair had to present from the back row because they came in kind of late? That sends a message. But the physical space makes a very important distinction between who is at the table, who is invited to the table, who has the ability to speak. The next one, when you're in a meeting, that makes a big difference, is the procedures. A lot of times we will go around and say, does anybody have anything? That's really common. Sometimes leaders will say, each individual around the room, tell me what your thoughts are, do you have anything else? And give everyone a chance to actually say something. I think that's pretty inclusive. That gives people a chance to say something. But what if you do that at 9:55 and the meeting ends at 10? The first person is going to have a very different thought process of what can I share versus the 10th person who now it's 5 minutes after, they don't really want to share. So we have to be mindful not just of the physical space, but also of the time and of how it comes across. That's the procedural part. And the next step, assignments. A very common practice in every meeting is to say, okay, who's doing what? What are the next steps? It would be very unique to have in the situation where someone from a different department, say pediatrics, ask the surgeon, what are your next steps again? If there's crosstalk between who is giving those next steps, who is assigned those next steps, that's a way to get that dialogue going, to be able to talk to each other. So there are many points along the way, along meetings, that can actually make a difference. Because it's Latin, this is old, right? Nihil de nobis sine nobis. Nothing about us without us. This is from the 5th century. And it's the idea that when something is done without the input of the people that it affects, it can be better. The disabled group advocates took this in the 90s to further their cause. They were able to say, don't make policies and plans for the disabled without having disabled people in the room. This applies for all policymaking. If residents had no say in workload hours, how effective is it? Now, as physicians, we want to often be paternalistic. Sometimes we've been there, we've done that, we know what the best thing to do is. But how powerful is it to be able to ask the people who are going to have to implement, who are going to have to be part of that plan to participate? So, for procedures, for policies, as much as possible, try to include the people who the policy will affect. And then the selection process. Again, this can be an entire lecture. When I was at USU, we had committees, we had people talk about this. We tried very hard to make the selection process better. We can have a discussion about what a meritocracy really is. And I'll tell you my quick 2 cents. A driver's license is a meritocracy. You pass the test, pass the driver's test, you can get a driver's license. There's an unlimited number, so it's a true meritocracy. Department chair, if there's only one, you have to decide out of these 3, 5, 10 candidates who meet all the qualifications, who is going to be selected. So it's not a true meritocracy because it's not just passing the bar. It's out of the group, I have to make a decision who is the best. So what can you do? Maximize the diversity of the team selected. Get as many people from many different specialties, many different points of view to be part of that group to decide who is going to be chosen. Meet prior. As soon as we start seeing candidates come through, we all have biases. We have a military bias. When you see somebody who was former military, we're already thinking, okay, we have something in common. A good selection committee will start before even seeing that very first person and say, what are the things that this department really requires? And if you have a diverse group of selection committee, your pediatrician may say to your surgeon, why is having 1,000 hours of surgical experience important for this administrative role? And the surgeon may say, you're right, that may not be as important. We just want them to have some experience. So deciding before people start coming in really improves your inclusiveness when it comes to selection. And then lastly, this is really, really hard. Asking a third party to give their opinion. We're selecting for radiology, the new chair. Let's ask someone in family medicine what they think a good radiology is our criteria for the next leader of radiology, something that they would approve of. It's hard to do. It asks for time, it asks for expertise outside your own, but it gives you a brand new perspective. It makes it more inclusive for all the people who are involved. And then I want to share a story just recently. One of my mentors and friends, Chuck Callahan, he writes a blog called Henry V. And just this November, he talked about the bat phone. When he was commander of a hospital, he instituted a policy where anyone at any time could call the number and speak to him, or if he was unavailable, they could speak to one of his representatives. That accessibility, that ability to talk directly to your chain of command, though not used very often, sets up the stage that your opinion, your people, they're important. They're included in what happens in the organization. Okay, let's get to the third stretch. The last part talks about what do you actually do? And I have to start again with another story more recently. Where I'm working now, we have a drive-through clinic for the COVID vaccine. And you can imagine all the steps along the way, right? Someone drives up, you get the right person's name, someone has to bring the vaccine out, someone has to administer it. Unfortunately, we have a group of patients who received the pneumococcal vaccine instead of the COVID vaccine. So fortunately not dangerous. It's not like they got Depo-Provera or anything like that. But they did get something that they weren't supposed to get. That is a QI issue. What if we treated incidences that related to diversity, equity, and inclusion the same way we treat QI issues? DEI, I tell leaders, it's like being the captain of a ship. You have to decide the direction. And as the captain of a ship, you're not actually always steering, but you decide the speed and the direction. And that decision makes a problem like that iceberg either bigger, or if you're going in the other direction from the iceberg, makes it smaller. So that's our role as leaders. To make these goals and to incorporate them into the DEI and the strategic plans, you know about SMART goals. This is how I would do it for a DEI issue. Now, say you've looked and you realize that there's a disparity in who gets put on probation. Well, my goal would be to get rid of that disparity. I would like it to be where you can't tell or you can't predict by demographics who's more likely to be put on probation. Is it measurable? Absolutely. We already know who's being put on probation. Are we collecting the demographics? Those two pieces of information are measurable. Is it achievable? If you make it to med school, you should be a doctor. 99% of the people who make it there have the ability. 99% do not become doctors. So, is it achievable? Absolutely. As an aggregate, can individuals have problems? Of course. But if it's predictable in your system that one group is getting probation more often than another group, that is not our goal. Is it realistic? Here's another little piece that might make you a little uncomfortable as an educator. Probation is more of a reflection of our programs, not the individual learner. If we thought that that learner was not going to succeed, we wouldn't have invited them into the program. We wouldn't have accepted them. Now, things happen, right? People have tragedies. All that is possible. But our assumption from the very beginning is that anyone who comes to us is going to succeed. And then over time. Is 2 years enough time? I think so. I think you may not be completely equal, but you can see enough of a change with enough of policy and work that you might be able to say, I can't predict who is going to fail based on their demographics. Now, I might base it on their test scores. I might base it on their first performance reports, but I won't be able to base it strictly on their demographics. So, pull out your phones again. I'm going to do this one more time. The same way you think about QI projects, I want you to think about a diversity, equity, inclusion, and accessibility project. So ask yourself, what have you recognized? What have you seen that you think could be a little bit better? Because you have to do this. We have to do this for our maintenance of certification. We have to think about how do we improve things. So I'm asking you now, think about what needs improvement. What can you do to improve BAMC? Your area, others' areas that you've seen. And this is not going to be a word box. It's going to free flow down. Good interviewing. Great. So a lot of people do talk about some of the disparities that happen in interviewing. We bring our biases to them. That might be a very good project. GME selection, collaboration. How do you improve collaboration between departments? Fantastic. That's your inclusiveness. Mentoring, committee membership, recruitment. These are all great things. As this scrolls down, keep that in your mind. What would you like to see improve? The diversity. Are you in situations where you're the only one? Inclusion. Do you come to meetings or been in meetings where you feel like you want to say something, but you know someone's going to shoot you down? Equity. Is your work being utilized? Do you have everything you need for accessibility to give power, to give energy to the organization? That's great. And I'll keep a track of this, and I'll give the committee this list, because it'll be a great discussion point in the future. When doing this work, we have to acknowledge the emotion. Identity is such a big part of this. As physicians, as healthcare providers, as people in uniform, we value service. We see ourselves as caring and desiring to help other people. So even the idea that I might do something that harms someone else by my action or inaction, that's a little bit jarring. That's emotional. It's vulnerable to talk about those things. You have to be vulnerable to address these things. But if you're an effective leader in the DE&I world, you think about your tools, you think about using all your tools, and you think about using the right tool for the right job. Don't like putting people quite as tools, but it is something, an analogy that really helps me to see it better. And I also want you to think as a leader about the term acceptable losses. Right? In combat, we know that there may be casualties. In medicine, there are going to be casualties. But it's very different saying, I don't expect 5% of you to come back, so we won't worry about you, versus we're going to try to get every single person back from this deployment. And if it doesn't happen, then we're going to look and see, well, what could we have done better? That is how we should look at acceptable losses. And I bring this up because a lot of times in climate surveys, we see 10% of people unhappy about something. And we're like, well, 90% are happy, so that's okay. But can we do something about that 10%? Is it worth doing something about that 10%? When it's as low risk as taking a stroll through the woods, you don't want to lose anybody. But if it's high risk, the reason we talk about the Swiss cheese model, we have all those safeties in place because even losing one person is unacceptable. All right, let me wrap up these three things, and then we're going to open it up to questions and discussions. When talking about data, it's important to know that we have biases, that there's ways to look at data in different ways, that if you build a team with different experiences, you're more likely to get better evaluation, better interpretation, look at your data in a better way. And then look at data over time. That's my recommendation. When it comes to inclusiveness, your meetings, the process, the physical space, the way you do it makes a difference. It can make people feel included or excluded. The policy that affects a group should involve the group. And selection requires a lot of pre-work. We like to think that we all have a baseline level of experience and talents, and we can just come together, pick somebody, and that person will be the right person. It's never that easy. When it comes to setting goals, think about how you do QI goals. DEI is really no different other than the emotional toll that it can play. And then actions will always, always, always speak louder than words. I can have 100 statements of my support for certain groups, but if I don't do anything, it's just ink on paper. I have 10 recommendations of podcasts that I think that if this is an area that interests you, that you should read. I sent, you can take a picture, but I also sent that you can have the meat of this presentation you can have. But these are the 10 podcasts that I think you would enjoy. The 7th one, they pronounce it the day shift. It's medical. And then 10 books. Of course, there are dozens more. But when talking about leadership's role in diversity, equity, inclusion, and accessibility, these are the ones that I think that you will get the most out of reading. I also like reading because it's our voice. It takes away that emotion that happens when someone is speaking or presenting. It helps you to listen to what is actually being said as opposed to how it's being said. All right? So now it's time for questions. What do you have for me?
I've got a question, sir.
Yes.
Miles Fisher, I'm a orthopedic P3. First off, thank you for coming in. I think we all really appreciate the talk. From your time at Walter Reed and at USIS, do you think that there are any specific challenges or benefits to improving diversity or recruiting a diverse medical student population from the military compared to civilian counterparts?
Good. So if you didn't hear it, I'll just repeat it. Is there a benefit in recruiting diverse populations in the military? Basically, was your question, right? So, again, if you think about diversity and the different experiences, just think about what happened with COVID. We had to go to telemedicine. If you didn't have anyone with any experience with telemedicine, you're starting from scratch and you have to build that all up. So getting students with different experiences, number one, gives you abilities and capabilities that you may not have. But more specifically, to recruiting people of different demographics, different ethnicities, different races and culture, there are numerous studies that say people take care of people who are like them and receive care from people who are like them better than from other groups. That's hard to hear, right? As a black pediatrician, that warmed my heart. That means any black kid I take care of is probably going to get really good care in the whole. But if I'm a white physician, does that mean that I can't take care just as well? No, it means you have to work harder. So recruiting different groups is really important because it allows that increased capability. It allows that flexibility to adapt when the world changes. Did I see another question? Yes.
You acknowledged that that green person on the treadmill is the hardest to motivate.
Yeah.
What are your suggestions for motivating those people? What's the best way of doing that? And what have you found effective in your own career?
I appreciate that question so much. I love talking about that because that is the focus of a lot of what I'm doing right now. When you have someone who is doing just great, looking around saying, why do I need to work harder? Life is good for me. It can be difficult. So that analogy I like too, because now you can see every single person. You're not doing it in a vacuum. That's where the teamwork comes back in again, right? If I can see that the person next to me needs some help, I'm much more likely to step my game up so that we all succeed. So that is the way that I focus it. That's the short answer, that once everyone sees that we're part of the same team, going in the same direction, doing the same thing, even the person who realizes that, I have more capacity to do more, they will step up because they want to see the same thing, same goal on the TV. I love the question. Thanks.
Yeah, I had, first, Paul Ellsworth, I'm one of the neurology staff doctors here, so I really appreciate you coming. It's a fantastic talk. I had a question about the example you gave of applicants from different racial backgrounds in medical school. You talked about white male applicants is basically cut in half from the 70s to now. Black male applicants are the same. So I'm wondering how to you're talking about interpreting data.
Yeah.
I'm trying to make sense of that in terms of how can you explain that? Is there a reason why there's half as many white men applying? Does that have to do with differences in recruitment, or increased opportunities for other groups? I'm sure it's a combination of those. But one of the things I struggle with, right, is when we're talking about equity, we're trying to get the same, or not the same, but broad diversity of experience in leadership positions and across the board. The percentage of the population is not the same for all these different groups too, right? So talk about it, if you have 10 leaders, do you want to have one male and female from white, black, Asian, Latino, LGBT? Is that the goal, or should it be a distribution based on the population?
Good. So you have two questions in there, and I'll answer both of them. The first one, you said exactly what I was hoping that most of the audience is thinking the same thing. Why? Why is there a difference? And my point with that data and that slide is to get you thinking, what are some of the reasons? Because it's not a simple answer. It's not as simple as recruiting. It's not as simple as other opportunities. It's not as simple as white men saying, well, my chances are low, so I'm not going to apply. Can those be factors? Absolutely. But like many behavioral things, it's complex. There's so many different things that made you decide to sit where you're going to sit. Each thing that we do leads to other decisions and has other influences that make things happen. So your first question is great. Keep thinking about it. Keep talking about it. Keep looking at the data. And ask yourself, why is that? Should we do anything about it? Which leads to your second question. Do we need one of each to make things work correctly? We don't necessarily want just numbers to have numbers, right? But again, I talked about the second law of thermodynamics, entropy. If things were equal, we would expect representation to be relatively equal. So when you look and you see that representation is not equal, ask yourself, why? Is it the system? Is there a barrier? Is there some wall that's keeping one group from moving over to the other side? And as you look at data, as you look at things and ask yourself, is this how it's supposed to be? Is this how it could be? Then you can start making changes. Nobody is ever arguing that, okay, starting today, everything should be exactly the same. Because we're not starting the same. If I put a high school football team against a college football team and say play, it's not going to be a game. But I'm going to do everything I can to get that high school team and those players ready to one day play on the college level. So that's my convoluted answer to your two questions.
I'm Kelly Kemp. I'm an old physician with a about my hair. I've been doing this for a long time. I heard Louis Sullivan talk about this back in the 80s, Secretary of Health and Human Services. He pointed out that there was a very low number of African Americans in medicine.
Mhm.
So I'm asking the opposite of his question, because that percentage that Louis Sullivan talked about back in the 80s still exists in 2021.
Yep.
So my passion as I get ready to leave this area is how do we get more people like you and like me to be part of this cohort of the medical professionals?
Thank you for asking that question. Another one of my passions is talking about increasing the numbers. I'm part of an organization called Austin Black Physician Association, and one of our goals is to increase the number of black physicians. People love the term pipeline. So pipeline, it indicates there's a resource, you drill and get the resource out, and if your pipeline is leaky, you're losing a lot of that resource along the way. Instead, I use the term pathway. A pathway says your goal is there, whether you're going to go through the chairs, around, or leave here and come out another way, your goal is still that pathway. So to answer your question, what do? You have to start from wherever people are. So you can't start as a senior in college. That's too late. You have to start elementary school, seeing people who look like them. You have to talk to those freshman college and freshman high school science teachers and say, stop being a gatekeeper. Stop telling these students, I don't think you'll be a doctor because you didn't do well in my chemistry class. We have to be able to help everyone see that potential is not skin deep. Potential really is the mentorship, the ability to come together and say, you belong. So how can we get you there? Yes.
Candace Percival, I'm
Hello,
the
Candace.
Director of Pediatrics, and I am so glad that question came first, because what I hear over and over as we're recruiting is that we're kind of stuck with what is already in the pipeline, exactly like what you're talking about. So having your GME and UME experience, I'd love to hear what you think our responsibility as program leadership, as here sitting at BMC and trying to recruit, how can we go about doing that in our roles?
Great. So your role and your statement is exactly right. By the time it comes for asking for applicants, you only can look at the people who apply, right? So how do you change that? It is all the other work in between. If you write a paper and everyone who writes the paper looks exactly like you, you're not spreading the wealth. You're not even giving other people an opportunity to think about medicine. We know that getting into medical school, now there's not completely written, but a requirement to have some clinical experience. How do those people get that clinical experience if they've never had the opportunity? So as leaders, as program directors, your job is to create that opportunity, to find ways to help people get their foot in the door, see if this is what they want, and then connect them with people who can go further. It is okay to mentor someone who doesn't look like you. In fact, it's fantastic. I love having mentors of all different types. One person is not meant to only have one mentor. We're meant to have as many people who can help us reach our goal as possible. Yes.
You kind of started to answer what I was going to ask. Let me start by just giving a little scenario, right? I'm a surgeon, and surgeons have this thing with medical students. You ask the medical student, hey, the music's playing, do you know who this is? Do you know who this is? Do you know who this is, right? Well, as a medical student, I couldn't tell you much about Guns N' Roses, Led Zeppelin, or anything like that, right? And now, as an attending physician, if I ask a bunch of medical students a bunch of questions about music that interests me, I probably would not get many people that could answer a bunch of trivia on 90s hip-hop, right? Mm-hmm. So my point is that though, what I realize and what I see is that people naturally gravitate to people that can answer or know these things and make them comfortable. That student knows this, they know this. And to some extent, it blurs the picture of, well, did they answer any questions about the actual surgery, or do they just know about,
music? Mm-hmm.
But here's what we also know. That many times, and my question to you is what can we tell leaders who are uncomfortable or who don't have the presence of mind to mentor across cultural lines, right? And so, and also to not cherry pick even the people that may be across cultural lines that are the superstar. How do we get the leaders to pick the average person, right? If we're going to be such great leaders, then we should be able to help people come along of all demographics. What can you tell people? How do we bridge that gap and make people comfortable with doing those things?
Great. So the first part of that is comfort is not guaranteed. That's why I started by saying, think about all the times we've been uncomfortable. Learning and changing is uncomfortable. So get out of your mind that we need to be comfortable to make a difference, because that is something that I talk against every time I have the opportunity. What can a leader do? So not every person should be a leader. We have to agree with that, right? And then if we think of medicine, what you learned in medical school, what if you stopped there and didn't learn any more? You'd be horrible. It's the same with leadership. If your leadership skills are not growing, not developing, you are not an effective leader. So what do I tell leaders who are not comfortable? One, if your goal is to be a good leader, you have to get out of your comfort zone. You have to do better. Two, who can you learn from? If you're not going to actually be the mentor, can you sponsor? Can you encourage someone else who you see is doing it right? Can you elevate the people who are doing the things that you see yourself as not able to do? And then lastly, if you can't do those two things, can you get out of the way? Can you allow the people who are trying to make a difference to make a difference? Yes.
Dr. Hutchinson, thank you so much for your presentation. I'm Dr. Berman, pathology resident. I feel like as military leaders, we always need to be fostering an environment and culture of DEIA. But I feel like we have an extra challenge that our workforce, our active duty workforce, is consistently turning over with PCSs and TYs and deployments. And I was wondering if you would speak to that additional challenge, how we overcome that with a team that consistently changes.
Great question. That actually is one of our strengths, all that turning over. Because once you realize I did this one way in this location, but now I'm here and they do it totally different, that is the perfect time to reset and think, well, maybe the way I did it wasn't so great. Or maybe I came into an organization that's doing stuff that's really jacked up. You should do it this way. So it can be a strength. Building the teamwork has to do with the mission. You know, I take care of teenagers, and in this work, I know that I'm not going home with them. I'm not going to go home, fix them, and make everything better. I have to believe that my interaction has some positive effect down the line. So you help people by letting them see the benefits of, even if they have a brief interaction, what they did made a difference. So in those teams, those people that come and go, we recognize what you did changed this person's life. What you did brought in these other people. Your short time with us has helped. Yes.
Question, what would be your recommendation if, as a leader, you go into an environment that lacks diversity? So when I went into my 05 command as a commander, I didn't have any diversity. I couldn't change them out because it's their assigned position.
Right.
How would what would you recommend for how to foster more of a diverse culture?
Great question. So you always have to start with learning your organization first, right? No one appreciates someone who comes in and says, okay, we're changing all these things because I'm now in charge. So you want to figure out, why is the culture like that? Are they already trying and hoping that things are different but don't know which way to go? Best case scenario, everyone has thought about it and sees the same thing you're seeing, but they don't know what to do. So you bring in someone who says, okay, let's make some changes. These are things that we can do along the way. Worst case scenario, you come in, say, I'm looking around and everyone looks the same, we should change it. And everyone looks at you and says, be quiet, we're fine. Then you have some work to do. You have to make the decision, do I fight from within or do I do my time and move on? And that's what happens with a lot of people who are onlys in certain situations. They decide, this is more of a fight than I want to fight, and I'm going to go someplace else. Practically, as a leader, what can you do? We talked about how to make things more inclusive. Some of those physical changes really do make a difference. And you're right, you can't fire everyone and bring in new people, But you can say to those people who are there, who are you working with? Who in your next assignment, outside of people who look like us, is helping you with this particular project? So the leadership may not change, but you can hold their feet to the fire and say who you're working with really should change. It really should represent the people that you're taking care of. Good. Good. Yeah, and as a lot of you probably know, this is not new. This stuff has been going on for a long time. I mean, if you read W.B. Du Bois' Soul of Black Folks, 100 years ago, the same questions were coming up. So we're incrementally moving. The military has come great strides. I'm very proud to have worn the uniform. But there's still a whole lot to be done. And if you look, people have tried things before that often work. Yes.
Sorry for more question. Your quote, nothing about this without internalize that. And I think one of my questions is, how do you recruit various groups of people without taxing the same people over and over when you don't have a lot of diversity in your organization?
Yeah. You can't. That's what happened. But if you acknowledge the work that I'm doing, it gives me energy to keep doing it. If the work I'm doing, I see the fruits of my labor, I have energy to keep doing it. As opposed to, we set up this committee, got all the diverse people together, they came up with a proposal, it disappeared. My energy just is gone. So it's the outcomes. It's what happens with the energy that I give you that makes a difference.